Friends, good evening. I know that this is tea time and the last session, but I would beg for your attention. First of all, thank you to the healthcare executive and the organizers for this very unique seminar. I've never been to one where so many talks with the social consciousness has been packaged, and I want to commend the organizers and the thinkers on the need for such a forum. Every talk has been inspiring so far, and I hope what I have to present will also fall in line with that as well. 8th September 2015 was a dark day in the history of Indian healthcare. This was the day when an 8-year-old child presented with a simple problem like dengue fever to 4 big hospitals in the capital of our nation. And in each of those 4 hospitals, for the sake of affordability and cost, treatment was denied. The child died of DIC and shock, and in the shock that overcame the parents, they jumped off from a 7-storied building to their death. This is 68 years after independence of a free India today that boasts of economic development, smart cities, Digital India, Make in India, so on and so forth. Somewhere else in India, in maybe Jharkhand or Bihar or Orissa, I'm just blinding it, you have another situation where there are hospitals or clinics that manage with just 1 pair of surgical gowns. And in the same area, there's, I'm told, doctors who use gloves from 1 packet, that's all there is in the public health system. And worse still, they are given 1 basin of boiling water, which has to be used to wash the surgeon's gloves for the next case, and also dip their recyclable instruments for the next cesarean section. This is India for you. This is an India that we don't hear about, but this is an India of which we are concerned about today in this forum. So my task is to talk about scaling up tertiary care in hinterland India. This is the topic, but it's a huge topic which cannot be spoken in half an hour, but I will do my best. But I must submit that I'm speaking from the perspective of an institution that exists in hinterland. When this hospital came into existence, many years ago, Vellore was not even a village. It was a 1-horse town with some traders doing business, and that was all there was. From 1900 to 2015, we have functioned almost from the same facility, a 19-acre campus which has a combination of clinical services, is a hub for medical education, and is also a center of innovative clinical population-based research. Are we a tertiary care setup? Yes, we are. Because if you look at all the success stories that we've had, it has gone from being a single bed dispensary in 1900 based on the founder's vision to a hospital which is now 2,600 beds, has about 8,000 patients coming from all over the country, mainly the east and the northeast, and also has about 8,000 to 9,000 staff, of which 1,500 are medical faculty. Is it only a tertiary care hospital? Absolutely not. It's a unique institution which has got primary, secondary, tertiary care, as well as what we call ordinary care, which is in a few areas that don't exist in the rest of the country. What I marked out for you in red is just to highlight where we are now, almost in a situation that we can't cope. From this 19-acre campus, it's become unhealthy and impossible to do justice in terms of quality care, because the environment is just choked with people, poor people, desperate people, people in pain and agony, who travel from as far places like Mukunda and Alipur and Guwahati and Arunachal Pradesh, undertake a 3-day journey to come to this hospital which for them is like a center of pilgrimage. I have asked this question, why do they come? Because we don't have the best buildings. Some of our buildings are 80 years old. We don't have the best parking lots. The roads are choked. We don't have lodges enough for these patients. But yet they come on stretchers and trolleys and wheelchairs. And Indian Railways is also wondering what is the magic that is there in this environment. Just to give you a snapshot of not our daily bread, our daily spread, of an outpatient which I mentioned, which is now touching 8,000, 2,100 patients, 160 to 180 big operations a day, 52 births in our labor room, bed occupancy of close to 80%, and an average length of stay of about 5.8 days, which will compete with any market figures. Let me just present to you 3 reasons which I believe are responsible for this excellence that is packaged in the comprehensive care that CMC provides. One is the age. 116 years, it started on the 1st of January 1900 on a dream that transformed the founder. The founder was a 25-year-old young lady who rebelled. She was a 3rd-generation missionary who ran away from famine-stricken Vellore, swearing never to come back to Vellore. But by a quirk of fate, she had to return from the US, where she was doing her studies, to an ailing mother. And one night, when she was sitting in her room reading a book, there was a knock on the door. There was a Hindu gentleman who, with folded hands, said, "Please come, my wife is dying of childbirth." She said, "I'm not a doctor, but my father is. Can he come?" She said, "No. No man can look at my wife." She said, "I can't do anything." And then he went away, saying that in that case, she must die. Very similar to the story that Dr. Neelam had described. And then an hour later, there was another knock on the door, and she thought this man has come back with a changed mind. But this was a Muslim gentleman who had the same story, and the same answer, and the same outcome. And another hour later, there was another man who came with the same story and was met with the same response. Bizarre story. You would say that this is dressed up, concocted, fabricated. There can be only 2 conclusions. It's a cock and bull story which we say to inspire people. But if it's not, then it's absolutely God-driven. There is something magical about this, because this experience, coupled by the fact that next day she heard that all 3 women died of obstructed labor, turned her around from a rebel who did not want to even stay in India, leave alone be a doctor, to a firebrand missionary who then went back to Cornell and became the first lady doctor trained in Cornell, came back and set up this one-bed clinic. To do what? To make a tertiary care center? Absolutely not. She had one vision. She wanted to respond to the needs of women dying in childbirth and children who were anemic. And from that beginning, it became, over the next 116 years, a big institution which has tertiary care in hinterland India. We talk about this philosophy called the both-and philosophy as our method of sustenance, and somebody alluded to this, that we practice the cross-subsidy principle because we are self-sustaining. There is no aid from the West or from the government, and in order to run this huge operation, we do what's called both-and philosophy, which is essentially our focus is on the poor and marginalized, and we offer them simple, clinical, bedside, compassionate care. But to do that, we also have to do the absolute state-of-the-art tertiary care. So this is both for the poor and for the rich, both for the villager and for the town person, both for local people and the rest of India, both service and education, both social consciousness and state-of-the-art scientific delivery. We are very vigorous with cost cutting, and I'll come to that in a minute, in terms of very low salaries for staff, concept of reduce, reuse, recycles, and no frills, which we don't believe is necessary when you give treatment to a patient like this. You would notice this is what's called the low cost effective care ward. There's not even a mattress or a bed sheet on the bed. But this patient will receive excellent care. Why? Because in his own home, he lies on the floor. And for him, the mattress or the bed sheet means nothing. What matters to him is the treatment that you get from caring physicians and surgeons. Do we have charity? It is mandatory. It's part of our philosophy to give generously, because we believe in our faith that to you is given freely, therefore freely give. Of course, we can't give 100%, but we keep aside 15% of our total turnover to subsidy, charity in crores, 124 crores year before last, and now it's almost touching 150 crores. Clinicians have got the autonomy to write off bills, to write off poor patients' bills without the administration or the management questioning them. The scene today is different. This is capital Delhi, choked in a state where even breathing is difficult. Not too far back, just last year, where children were presenting in hordes to the hospitals in Delhi because they were having wheezing and asthma and COPD and all the rest. Difficult to commute on the roads without these kind of masks. This is urban India for you. Last year it was Delhi, next year it will be Bangalore, and soon this will be in all the urban cities in India. What about hinterland India? We are talking about tertiary care. But this is a fact of Vellore. This is a suburb of Vellore. Just look at the way people in the town of Vellore live. No consciousness of dirt, disease, and degradation. They just live. And they acquire diseases which they can't cope with. Or if you go to the village, it's like this. They're just shacks. Just a hiding place without a pillow or a mattress where they just sleep after the end of a day's work. These are the rural rockets. They drive without any concern about safety or impending death. This poor lady is sandwiched between her two sons, desperately going to work to earn their living. And in 10 minutes from now, they could become victims of a speeding truck coming on the opposite side of the road. This is India for us today. This is from our hinterland clinic, where this villager presented with this horrendous accident, run over by a jeep. Or injuries like this, which is not in the city, but it's in the town. It's in hinterland India. Can you do primary care, or do you have to go to tertiary care is the big question. India is changing. It's now 1.3 billion. The economy is on the rise. There's urbanization, which is not good. The widening social gaps are becoming a problem. There is decline in ethical values everywhere, even in healthcare. There are political changes that are not necessarily auguring well for the benefit of people as far as health is concerned. And there's a very serious epidemiological transition that is taking place in the changing profile of diseases of our country. And therefore, the challenges of tertiary care in hinterland India, in towns and villages, is not going to be tuberculosis or malaria for a long period of time. It's going to be this. Tamil Nadu leads India in terms of road traffic accident, morbidity and mortality. There will be lifestyle diseases. You drive on the village roads, you will see not paper packets, but empty sachets, Tetra Paks, Lay's chips, Kurkure, and the works. Because the children are getting the messages from internet and schools that that's the way to go in order to live with the same kind of hype. Environmental diseases, dirt and degradation, smoke, pollution, fumes, petrol fumes, what have you. Cancer, because of all this, is on the rise. 50% of cancer cases are in the villages. 95% of cancer care centers are in cities. Just look at the gap. Where will the twain meet as far as demand and supply are concerned? And of course, a growing cohort of healthy people who are living into their 80s and 90s, and unhealthy people who are surviving the problems of middle age and are surviving into their 60s. Both come into the geriatric care group. A huge cohort of people. And I would add to what Neelam said, that we are also going to have, by 2030, the world's largest number of elderly people in the world, overtaking China. The reality today is this, and I think this is a strong message. We never allude to healthcare as service. We allude to healthcare as industry. Just imagine, we've made an industry out of human vulnerabilities. How can we do this? Can we make an industry of somebody's pain, somebody's sorrow, somebody's anguish, somebody's lifelessness? But that's what it is. And there are enough of printouts in magazines that vouch to the fact that we have sold our soul as far as healthcare business is concerned. The reality today, and this is a government statement, is that healthcare cost is the leading cause of poverty in our country. What a paradox. What an ironical statement. That healthcare, which is meant to make you good enough to overcome poverty, has become the leading cause of poverty in our country. Not my statement. It's a statement of the National Health Policy Draft. Public health has gone down, promised to go from 1.6 to 2.6, but they went in the reverse trajectory. 1.6 to 1.03, the lowest in the world, one of the lowest in the world. An ethical decline in healthcare, evidenced by the fact that there are people who are documenting this. Unnecessary investigations, unnecessary surgeries, unnecessary treatment schedules that are all being given to unsuspecting patients because targets have to be met. Somebody has built a big hospital and the banks have to be paid, and therefore investigate. I'm being truthful and honest of what healthcare is heading to. We talk about health tourism as a good way of business, but just look at this picture, it says it all. In the foreground is slums, where people don't sleep, or there's a man who's under the influence of alcohol. There is HIV, there's tuberculosis, and in the background there are aircrafts that are bringing in sheikhs, rich sheikhs, to big hospitals because it's a good way to make money. What about Indians? Where do they go in the system? So what's the future? We're talking about scaling up. This is the scaling up we see. Just look at the risks that we expose, and this is symbolic of the different kind of risk behaviors that we as Indians are putting ourselves into. But if you want to talk about scaling up care, I want to submit 5 Bs. The first is to build appropriate infrastructure. Shilpa just gave a fantastic talk on what this could be done and how it's being proven. Do we need hospitals like this? This will cost $1 million. Do we need Taj Mahals to become hospitals or hospitals to become Taj Mahals? Absolutely not. Do we need suites like this when somebody comes for a fracture? I don't think so, because this is what is shooting up healthcare costs. But what you need is probably this, the old infirmary, the old dormitory, where care and medical issues are given primacy, not the bells and whistles that we talk about. Bettering available facilities. There are good hospitals which are run down, and I think there's enough of money in corporate world to tweak those through right agencies to make those primary healthcare centers and sub-centers and government hospitals into sanctuaries of good clinical care. We have to boost appropriate manpower. I think as part of the healthcare fraternity, as part of corporate fraternity, we have to make a pledge that India needs corporate money, not to buy more missiles and guns and ammunition, not to build more malls or high-rise apartments, but to build more sustainable hospitals. We have to buy appropriate technology. With all due apologies to the IT world, all technology is not good. There is only few technology that lasts a lifetime, because technology changes like a chameleon. What you have bought today for 1 million, within 6 months is obsolete. There are new software updates, there's a change system, there's a changed operating system, and you're forced to buy it again. Bridging affordability gaps by whichever way that we can think. I think a treatment room like this, even in a corporate hospital, is just as good. There will be less infection, and the cost of doing the same procedure will be 1/3 of what is charged today. If we are talking about tertiary care in hinterland India, this is the way to go, not the original picture that I showed. A few extra words about technology is overstated. This is a group of smart IT people who talk to lay people in complex language and symbols and signs, which we get very impressed with. But we've got enough of examples where technology does not really meet the demands of the man who is coming in pain. Electronic medical record is a classic example of why it's creating a distrust, because the interface of a monitor between a sick patient and the doctor is a major problem. We don't look at the patients anymore. Is that the care that we are talking about? It's a good slave but a bad master. Technology is good, it's necessary for medical care, but it's a back-end facility. It can never replace the clinician. It drives cost up, we know it. There are softwares which will cost you $1 million. They will package it with 100 things which you don't understand. And before you know, they are charging you for updates and licenses, and maybe slap you even a fine for having used something accidentally. That's the software industry, not the healthcare industry. It is replacing service, as I mentioned. And there are certain trends which today morning it was highlighted about, and I think as entrepreneurs, we need to take this, and this is backed up by some research that we did in our own institution. The profile of hospital care and healthcare is set to change. It's already changed in the West. If you look at the state statistics of any hospital, the number of beds required for 3 areas, emergency, intensive care, and acute care, is huge. There are waiting lists. Any amount of beds are not enough. There is a reciprocal decline in chronic care beds. You come to our hospital, we can get you a cardiac bed like that. Nobody wants to get admitted for more than 1 day. Angiogram is now a half-a-day procedure. Angioplasty is now a 1-day procedure. So there are enough beds available. And this is true for gastroenterology, for nephrology, for dialysis, this, that, and the other. People are preferring home-based care. Already in the US, domiciliary nursing systems are already reality. It's going to come to India soon, and of course short stay care as well. So I think with this, if we are talking about bringing tertiary care to hinterland India, it's about doing those 5 Bs. Rebuilding or re-understanding healthcare infrastructure. We don't need to make palaces, but we need to make infirmaries. The good old infirmary, the good old dormitory, the good old system where the clinician and the nurse were the primary caregivers, not technology, has to be revisited. We have to choose appropriate manpower. Take a pledge that money is not the reason you and I are here. It is because we are chosen to deliver solace and succor to the most vulnerable section of our society. Women who are anemic, children who are malnourished, old people who don't have hope. And that's our mandate. And I think from the picture that I showed you of a choked, polluted urban network, healthcare has no choice but to move gradually to hinterland of India. Places like Vellore and Hosur and Thane and Nagpur. Thank you.
Mr. Sunil, thank you very much for a very good presentation. which is very much required to the present generation here now. You spoke really very nicely what Vishal spoke in the morning about oncology, and all middle class people or the low class people or people not earning more money, the present generation, the present thing, all should be afford to get medical attention. Medical is most important nowadays, become more costlier and costlier. People not afford to have treatment. But the way in which you presented the arrangements or whatever that is available in Vellore hospital, it really hats off. And every hospital, every people, everybody should think of the same line that how to treat people with middle class and lower middle class people. Thank you very much for the presentation. It's very nice indeed. Thank you.
Floating population, they come for training, but they are part of our caregiving front. They are involved with patient care. We don't believe in didactic teaching our postgraduates. They have to learn on their own, but they put on duties and they are really the frontline soldiers of clinical care. That's part of the training philosophy. But if you ask me the question, what inspires them to say, there are several things. One is that the process of getting them on board to the philosophy of missionary work or compassionate work starts from the medical school. They are exposed to village life 3 times during their 4-year course. In their first year, they go for 1 month and they are asked to stay in the village. Not to do medicine, they are in their first year. What do? They are taken to a village, they build their own thatched accommodation, they build their own toilets. They are expected to go into the village and adopt a family. So they talk to them, they understand their lifestyle, they identify problems, and then they follow them up through their clinical years. In the 3rd year, they go with some specific project, like maybe just hookworms or disability or whatever. And in their final year, they do a case study. So the intention is to expose them to the real India. Because in a medical college, they are in an ivory castle. They are protected. They have somebody advising them through and through. But it does not prepare them for ground realities. Apart from this, during their holidays, they are expected to go to a hospital in some place in the other parts of the country. They go to Makunda, they go to Alipur, Tezpur, Udanchakram. They are really remote areas where they spend 3 weeks under the tutelage of a faculty member who accompanies them. So they take clinics there and help them through their clinical problems. And then after they graduate, 2 years, they have to compulsorily work in a mission hospital before they come back for post-graduation. So I think these kids get exposed and they get convinced that there is a need. And this is why we have 65% of our undergraduate alumni who stay in our country. 65%. So that's a record.
Thank you, Dr. Chandy. May I request Dr. Vivek Desai to please come and hand you the memento.